Professor Bishara, dear Chairman, ladies and gentlemen. I would like to thank the organizing committee for inviting me and for giving me the honor to speak to some of the best doctors in Egypt, the vascular surgeons. My presentation was titled Optimal Medical Therapy in Peripheral Arterial Disease. And Professor Bishara asked me to be specific about the anticoagulation antiplatelets. So I went to the guidelines. The guidelines are actually ours, of the European Society of Cardiology, in association with the European Society of Vascular Surgery. So they are common guidelines. We also have to remember that optimal medical therapy is not just pills or doing things, but actually involves a lot of lifestyle modification. And it is part of the vascular surgeon's job, if there's no integral system in the hospital, to actually direct their patients to smoking cessation. We know how important is smoking cessation in patients with peripheral arterial disease, and certainly the vascular surgeon should not be himself a smoker, or at least shouldn't be proud of this. This is a class 1B indication. You should also direct the patients to healthy diet and to physical activity. We know that of all the vascular disease, especially the disease of the lower limb, the arterial disease of the lower limb, physical activity might be an essential part of the cure. And again, this is class 1A by level of evidence, just the agreement of the experts, C. All patients with peripheral arterial disease should receive statins, even if they have totally normal cholesterol level. Don't fall in the trap of analyzing the lipid levels. Everybody should get statins, and we're going to go through this very quickly. This was the older reduction of the lipid profile, which changed this year. I won't even go through it. In your diabetic patients with peripheral arterial disease, you should be involved in a multidisciplinary way with the diabetologists, and you should make sure that strict glycemic control is achieved. All patients with symptomatic peripheral arterial disease should receive antiplatelet therapy. Again, the level of evidence is 1. The class is 1, class of recommendation is 1, but level of evidence is C, expert opinion. Patients with peripheral arterial disease and hypertension should have their blood pressure brought down to below 140/90. And for those particular group of patients, ACE inhibitors and angiotensin receptor blockers should be the first line in therapy in those patients with peripheral arterial disease and hypertension. So when we talk about peripheral arterial disease, what are we talking about? We just saw Professor Bassiouni talk about peripheral arterial disease of the head and neck, which is the carotids. And of course, we're also going to talk about the legs and other beds. So in the carotid artery stenosis, you have 3 types of patients. You have the asymptomatic carotid artery stenosis patient, which Professor Bassiouni just mentioned in the last question. The patient, 80% of them will probably live their lives being asymptomatic. And all they need is a single antiplatelet therapy, what we call SAPT, which is usually an aspirin 100 milligrams a day, 75 to 100. If the patient has gastric intolerance to aspirin and you want to replace it with clopidogrel, you can. And that again would be SAPT. And the level of evidence is not very strong, class 2A, C. Now, if the patient had received carotid artery stenting, they get 1 month of dual antiplatelet, which is usually aspirin and clopidogrel, and then long-term, at least 1 year, possibly longer, of single antiplatelet, again, aspirin or clopidogrel. If the patient has received carotid surgery, they get single antiplatelet long-term, at least for 1 year and possibly for life. So if you do and go in and do an endarterectomy, you do not have to give aspirin and clopidogrel. The guideline says you can just give one of them. We have to remember that over-treatment with antiplatelets carries a risk of bleeding, so we have to know the guidelines. Now, what about patients with leg disease, lower extremity disease, which are usually worse than those with carotid in general? If they're asymptomatic, they actually don't need antiplatelet at all. There's no reason to give them antiplatelet if they don't have other medical reasons, and that is the red on the left. If they're symptomatic, you have a class 1A recommendation to give a single antiplatelet, and that's long term. As long as they're symptomatic, they take an aspirin or a clopidogrel. If they had undergone revascularization, whether it's percutaneous in yellow, they get a dual antiplatelet for a month, and then a single antiplatelet for at least a year. If they had undergone surgery, they get a single antiplatelet or an anticoagulant. And the class of recommendation is not very strong. It's 2B, which is closer to 3, really, B, based on one trial. So these are what you do with the patient with the leg disease. So what about the patients with leg peripheral arterial disease, lower limbs, who require oral anticoagulation for a variety of reasons? One of them is peripheral vascular, but the other one could be that they have concomitant atrial fibrillation, for an example. If they're asymptomatic or they had undergone surgery, they should undergo single treatment with oral anticoagulation, whether that's warfarin, vitamin K antagonist, or one of the new ones, which we're going to discuss briefly. If they had undergone a percutaneous intervention with or without a stent, then they need dual antiplatelet if they have low bleeding risk for a month, and then possibly extended or just single. Or if they have high bleeding risk, then they only take oral anticoagulation monotherapy. They don't get given antiplatelet at all, okay? Even now in coronary artery disease, we've realized that if the patients are on proper anticoagulation, the antiplatelet just gives them an additional risk of bleeding and no real benefit, except possibly in the first month after intervention. So these are the guidelines, what we just discussed, put in a table, and I won't go through it for the sake of time. After infrainguinal bypass therapy, single antiplatelet. In patients who are receiving antiplatelet therapy and you want to give single antiplatelet, some prefer clopidogrel over aspirin. If you perform an autologous vein infrainguinal bypass, class 2B, again, not very strong, vitamin K antagonist might be considered. And these are the rest of your grafts. You know this very well, and presentations outside. Because of lack of proved benefit, antiplatelet therapy is not routinely indicated in patients with isolated asymptomatic lower leg peripheral arterial disease. If you have atrial fibrillation, you should know how to calculate the CHA2DS2-VASc score, which is the score that tells you what is the risk of your patients getting a stroke. And it's pretty simple. I mean, you basically look if they're a man or a woman gets 1, and then if they're hypertensive, if they have diabetes, if they have previous stroke, they get more points. Any patient with a 2 or more is recommended to undergo oral anticoagulation. Other patients with lower scores can be considered individually. If the patients require oral anticoagulation and they undergo endovascular revascularization, you should consider adding aspirin or clopidogrel, single antiplatelet, in addition to the oral anticoagulation for 1 month if your patient's bleeding risk is low, compared to the risk of stent or graft occlusion. So for instance, if you have a very large stent, an excellent flow, and it's not drug-eluting, it's like an iliac stent or a renal stent with excellent result and normal flow, this is a low risk stent occlusion. If you have a stent in the lower part of the leg and you end up with a suboptimal result and the flow is not excellent because its stellity is really diffusely diseased, this is a stent at a high risk of thrombosis, especially if it's a paclitaxel stent. And for those patients, you really do, it's a very, very tailored treatment. You need to look at it. And oral anticoagulation and single antiplatelet may be actually considered beyond 1 month in high-risk patients, or when there's another firm indication, such as the patient I just described. So a quick question. Which antithrombotic treatment after intrapopliteal PTA without stenting, without high bleeding risk, would you give? Would you give single antiplatelet with aspirin, or double with aspirin clopidogrel for 1 month, or double with aspirin clopidogrel for 3 to 6 months, or double dual antiplatelet with aspirin clopidogrel like permanently or long term, or dual antiplatelet with aspirin and rivaroxaban 2.5 long term. And the answer is aspirin 100 milligrams permanently, and possibly clopidogrel 1 month, or you don't need to give it. But look at what's in black. What's in black is probably as important as the antiplatelet therapy, which is the rest of what we call OMT, optimal medical treatment, because the patient comes as a package. And it's very likely that once the patient comes to you, they're not going anymore to other doctors. So you might at least need to check that they're taking the proper treatment. The patients need to be on the maximum statins that they can tolerate. We're talking about torvastatin 80 or rosuvastatin 40. They need to be on an ACE at the large dose, which is proven in trials like the ASCO trial. This is just an example, like prindopril. And they need to be on their anti-diabetic treatment. So what if you don't perform a PTA, but you perform infrapopliteal stenting? Which of those regimens would you use, and the patient does not have a high bleeding risk? You are going to use a dual antiplatelet because you put stents for at least 1 month and preferably for 6 months, again with the optimal medical treatment. So what if you put a stent and the patient comes back in 6 weeks' time with a thrombosed stent and subacute ischemia of their leg? What are you going to do? Are you going to keep them, and you fix it, you go in and you fix it, whether with a balloon or with another stent? Are you going to put them on dual antiplatelet with aspirin and clopidogrel for 1 month or 6 months or long term? Or are you going to replace with one of the more potent antiplatelets like ticagrelor or even rivaroxaban, which is an anticoagulant? Actually, you can use a dual antiplatelet long term. You can use any of the previous strategies, but normally you would use dual antiplatelet long term. Possibly, if there's no contraindication after stent thrombosis, you need a really long term of at least 1 year, if not longer. There have been very recent data presented in Paris less than 1 month ago about the antithrombotic therapy in diabetics, where they looked at type 1 and type 2 diabetes-related cardiovascular death, and they found that those patients still die, even though there's an improvement, but they still die more than other patients. And in patients with diabetes mellitus at high and very high risk, and I'm going to explain what's very high risk now, they may be actually considered for primary prevention by antiplatelet therapy in the absence of clear contraindications like a gastric ulcer. In patients with diabetes and only moderate risk, do not give antiplatelets. So we don't give antiplatelets for primary prevention in patients. And if aspirin is given, you have to give a proton pump inhibitor. This was the COMPASS trial, which will change the practice of peripheral vascular surgeons, because in this trial, in patients with stable coronary artery disease or symptomatic peripheral arterial disease with additional risk factors, which I'm going to describe now, the patients were either given aspirin or rivaroxaban, which is Xarelto, 5 milligrams twice daily, or the small dose of rivaroxaban, which is 2.5 milligrams twice daily with aspirin, and they were compared. And very interestingly, the group which did best was the black group, where the risk of death, stroke, or myocardial infarction was lowest, which is the combination of both drugs in low doses. So rivaroxaban 2.5 twice daily and aspirin. And of course, this came at a price of extra bleeds. However, even though there was a significantly increased rate of major bleeds, there was no increase in fatal bleeds, no increase in non-fatal symptomatic intracranial hemorrhage, or non-fatal, non-intracranial hemorrhage, symptomatic bleeding into critical organs. Just major bleeds which require blood transfusions, but none of the very scary bleeds were higher. So it's a good practice. And if you added pantoprazole to this, it really decreased the incidence of gastrointestinal bleeding, which is the commonest bleeding that was encountered, and this does not come at a price. No death or stroke with the pantoprazole. And this led to introduction of this combination in the new guidelines of 2019, recommendations for diagnosis and management of peripheral arterial disease in patients with diabetes and chronic symptomatic leg ischemia without a high bleeding risk. A combination of low-dose rivaroxaban and aspirin can be done. This is just explaining what is the very high risk and what's the high risk. Please take the slides from the... And now we have to take the very high risk patients to cholesterol below 55 milligram per deciliter, and the high risk to below 70, that's the LDL. and the moderate risk to 100, and the low risk to 15. And we have the tools to do that. So if your patient who has severe leg ischemia, who is classified as very, very high risk in this group, if you look at their lipid profile, you actually need to bring those patients' LDL to below 55. And you can do that by maximally tolerated statins. Give them a month. If they haven't reached that figure, add ezetimibe. Give them a month. If they haven't reached that figure, either prescribe a PCSK9 yourself or refer them to a lipid specialist. Thank you very much. I had some more slides which I'd quite like you please to take from the audiovisual on how to reduce bleeding when you're planning to operate, and how to assess the bleeding risk, and how to when to interrupt anticoagulation if you want to perform a leg surgery, and when not to interrupt. And if you interrupt, what do you do? When do you interrupt? And timing of antithrombotic interruption. And should you bridge? Because we see the bridging practices using enoxaparin, which is sometimes harmful. Not all patients need bridging. All that is in the presentation, but of course due to time and when you can restart, due to time I can't present it, but please, on your way out, just take it from the audiovisual. Thank you very much. I'm happy to take any questions.